Great. Good morning, everyone. They told me I had 9 minutes to speak and do introductory remarks. Like, wow, that's a lot to say. And then they said that everyone has to introduce themselves in that time. So I'll be incredibly brief because this is meant to be an action-oriented conversation. But I'll start just with echoing the thanks to the planning committee, to the funders, to the National Academy staff. It really has been a pleasure to work with everyone. And I think we have set a great table here today, a crowded and great table. And as I walked in the room, I said to Katie, wow, this is unlike a National Academy of Medicine meeting. It's intimate. We're together. Normally we sit on the outside and you're in the august hollowed square, but I like the fact that we're together. It's a tight group and we're going to have a conversation. As to echo Jeff and Michael, this is an action-oriented conversation with people who've been living this and experiencing this both as patients, as providers, as payers, as policymakers, and our intention is to bring this group together and move the conversation forward. Just want to make 3 framing remarks, and Dr. King could say everything better than I could ever say, but just want to frame the discussion today with 3 of his quotes to lead us off. The first, faith is taking the first step even when you don't know the whole staircase. And if that's true of this conversation, right, this is an act of faith. We don't know where this is going to end up in terms of making this the standard of practice across the country, using these models, understanding what's standardized and what's customized. We have some notions, and what we are doing is taking the first steps on those journeys, and we are combining all the other first steps that folks have made. But our goal, let's be clear, is to get up the staircase, right? It's not just to understand the staircase. We're not here to understand staircases today. It's actually to walk up for better quality care. The second is, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. We know a lot, right? 482 pages. Thank you, Katie. Anyone who needed to read that and needed to get some good sleep. We have 482 pages of nighttime reading for everyone. If you didn't get through it before the meeting, I hope you'll keep working on it afterward. But that tells me that we know a lot, right? That we understand there are models. There is a huge amount of shared knowledge that we have on this. So our obligation is more than just our task today. It's our obligation to figure out how do we make sure that that becomes reality for folks who have high needs, patients with high needs in their families. I mean, so it is not enough to understand it. I mean, it's the Academy of Medicine's, National Academy of Medicine, National Academy of Sciences. It's to do, it's to act. And so I think if we don't act, that is injustice. We know things, we have capability. If we are not making that available to patients across the nation, then I actually think it's where we have created an injustice in the world. And then third is our charge today. We must use time creatively and forever realize that the time is always ripe to do right. Today is our time. It is ripe. I mean, if there is an issue that is ripe in healthcare, it is how do we provide better care at lower cost for high needs patients. We've talked about it. We've done lots of great work. There's been a lot of work over decades now on this topic of analysis, models, prototypes, evaluations, and now the time is ripe for action at scale. So this morning we're going to look at understanding the issue, segmentation of the population. We know when we use the term high-need patients, it's a heterogeneous population. It is not monolithic. There is the high-need patient. It's an incredibly diverse group, which we've learned. And so part of this morning's exercise is to understand the complexity and diversity, and then move into practice, and move into what are the design elements after lunch. If you're thinking about designing a care system for these populations and for these individuals, and then what's the policy framework that underpins it? We think you need to do all 3. You need to understand the population, understand the design elements, and then think about a policy framework that's enabling and supportive. So that's the theme for the day. It will be a conversation. We'll have presentations that will stimulate our interest, but we chose to make this a small group to make it a dialogue and to give people around the table an opportunity to speak with one another. A couple of housekeeping, and then we're going to introduce everyone in the room and begin the conversation now. Slides will be available after the meeting with the permission of our presenters. So we'll get the slides. I think I've seen them all, and they're an amazing set of information. I think they're distilling the key elements for us to frame our conversations. The meeting is open to the public via webcast. So we are being webcast, and we're open to the public. If you'd like to speak, please raise your tent card. And if I really can't see you and you're kind of raise it up in the air if you need to, because I might not be able to see everyone on this side, but if you're speaking, raise your tent card. We're going to have a working lunch. This is if you looked at the agenda, we're here to work today. We'll have a working lunch. After the first breakout session, we're going to get boxed lunches and then come back into this room and keep right on working. So, without further ado, let's start. I'm going to go into the far corner there to my friend John O'Brien. And since there are a lot of us, and I've eaten 4 of our 9 minutes, if you could just give your name and affiliation so that we know who's in the room, and we can start. Thanks.
Hi, Terry Westbus, Nurse for Medicaid Services.
Simon Hamish, Denver Health.
Paul Blanker, Optum Labs. Jose Figueroa, Harvard School of Health.
Terry Fulmer, Jody Hartford Foundation.
Frank Sassi, National Voters Association.
Ashish Shah, Harvard School of Health.
Phil Closer, B. Corey.
Let's go this way.
David Atkins, VA. Veterans Affairs.
Darcel Jackson, Children's National.
Randy Brown, Athletic and Policy Research.
Adam Kraft, CMS.
Ian Schwartz, Medicaid and Chip Payment and Access Commission.
Joanne Lynn, Carver Institute Center for Elder Care and Advanced Illness.
Lauren Harden, Trinity Health, and the American Academy of Nursing. Lauren Burns, Adelaide Health.
Ron Blanford, Threshold.
I'm Jerry Anderson, Johns Hopkins University.
David Myers from the Agency for Healthcare Research and Quality.
Diane Stewart, Pacific Business Group on Health. I'm Michelle One.
Craig Simon, Anthem. Bruce Ternopoulos, Care Foundation.
Melinda Abrams, the Commonwealth Fund.
Risa Brady, Providence Health Services.
Christine Agnew, Association for Community Affiliated Plans.
David Dorr, Oregon Health and Science University.
Susan Frampton, Plaintree.
Conley Corey, Lehigh.
Don Goldman, Institute for Healthcare Improvement in Boston Children's Hospital.
Peter Bowling, Virginia Commonwealth University.
Mark Miller, Medicare Family Advisory Commission.
Lauren Murray, National Partnership for Women and Families.
Emily Bordovich, Peterson Federal Healthcare.
Frank Agree, Family Medicine University.
And let's go here, and then we'll do that.
Steve Council, Indiana University.
Pastor Bruce Hanson, Macquarie and patient advocate, steroid caregiver.
Thank you. And how about let's go down here, the outside.
Elijah Albert, on your right.
Great. And on this side here.
Chris Workman, Fine Arts Policy Center.
Laura Parker, Allendale.
Gretchen Alcama, the SCAN Foundation.
Amy Berman, the Johnny Hartford Foundation.
Marcus Escobedo, Johnny Hartford Foundation.
Augie Gilman Park.
Tonight we'll have CMS.
Sandra Wilkins, National Governors Association.
Samantha Conrad, Florida Children's National.
Great. Thank you all. So we're going to get started. So Darcel. One of the things we said as a planning committee is oftentimes we can have theoretical conversations in the abstract about how do we change the system for high-need patients. And for those of you who are at the first workshop, we made a decision as the planning committee we would start every workshop with a person's lived experience, that we come from the human condition and from people's experience so that all the rest of our conversation is framed by that narrative and by that story. So I'm very pleased to introduce Ms. Darcel Jackson, who is a patient navigator at the Goldberg Center for Pediatric Primary Care at Children's National Health System in Washington, D.C., providing support to families of children with chronic medical conditions and complex health needs. At Children's Hospital, she is part of the Primary Medical Health Champion Team and Children's National Patient and Family Advisory Council, among other activities. As a mother to a daughter with complex health needs, Ms. Jackson is committed both professionally and personally to improving care for high-needs patients. So this is, without further ado, Ms. Jackson.